Good morning. This webinar offers closed captioning. To enable closed captioning, click on the live transcript button on the bottom of your screen and choose your preferred method. Welcome to the Chicago Department of Business Affairs and Consumer Protection webinar. Please note any website or email that I mentioned will be posted in the chat. For those seeking business license assistance, you can visit the Small Business Center here at City Hall or call 312-74-GO-BIZ. Also, business license can be applied for or renewed online at Chicago Business Direct. If you are a part of the BACP Entrepreneur Certificate Program, you can get credit for joining this webinar by sending an email to bacpoutreach@cityofchicago.org. To learn more about this program, please visit chicago.gov/business education. This webinar is being recorded and will be available at youtube.com/Chicago BACP. We encourage attendees to ask questions. Please use the chat box to send your questions. There will be a Q&A session at the end of this presentation. Today's webinar is entitled, Get the Facts About Monkeypox, presented by the Chicago Department of Public Health. At this time, I will now turn this webinar over to the Deputy Commissioner of Public Health for us to begin.
Thank you. Hello, everyone. I'm Massimo Picciulli. I'm the Deputy Commissioner for the Disease Control Bureau here at the Chicago Department of Public Health, and I'm coordinating the work of many here at the department for the monkeypox virus, or MPV, response for Chicago. Along with colleagues here on the call, we'll present some information and provide some answers through frequently asked questions. So I'll turn it over to Dr. Karen.
Hi, everyone. My name is Dr. Jana Cairns. I'm a medical director, also working in the Disease Control Bureau and helping to coordinate the monkeypox or MPV response here as well. I'm going to turn it over to Deputy Commissioner Dave Kern.
Good morning, everyone. My name is Dave Kern, and I'm the Deputy Commissioner for the Syndemic Infectious Disease Bureau, which includes HIV, sexually transmitted infections, viral hepatitis, and tuberculosis. And our Bureau is providing support to the department's monkeypox response. And I'll turn it over to Patrick Stonehouse.
Thank you. Good morning, everyone. My name is Patrick Stonehouse. As mentioned, I use he, him, his pronouns, but anything with respect is fine by me. I'm a Director of Public Health Operations with Syndemic Infectious Diseases Bureau, as Dave just described, specifically focusing on community health services activities. And the reason we're bringing you all together today is that MPV, monkeypox, we're trying to use MPV more than monkeypox, just because it's a little less icky feeling for folks. It's here, and it is spreading, and we are doing what we can, everything we can, to try and control the spread of monkeypox. We'll have further details of like where we're seeing it, what populations we're seeing it within, but we've been getting together since monkeypox first started showing up, talking with clinical providers, delegate agencies, key stakeholders in our priority populations. And now is the time when we wanted to bring businesses together so that we could rally together, share information, come up with strategies, forge connections as appropriate, and answer any questions that you may have or that you have heard from your staff, your employees, your colleagues, your friends, your lovers, your neighbors, just to get the conversation rolling and connect you with all of the available resources and information that we can at this point. And so this is, as was mentioned earlier, we'll give a presentation, we'll go over questions and answers, and hopefully this is the beginning of an ongoing conversation between businesses and the health department about how we can best improve the health and health outcomes of Chicagoans moving forward. And so I will hand it back over to Massimo.
And actually, I'm going to start out. Massimo, you're on mute, so thank you for.
Great. I was going to pass it on to you.
Okay, so I just wanted to start out with giving just like a brief overview of some of the data and where things are at right now. So this is as of yesterday. We're now seeing over 18,000 total confirmed cases of MPV in 75 countries. So this is really spread throughout the world. Next slide. And then specifically in the United States, we're up to almost about 3,500 cases. And now most states have had at least one case. Next slide. So in Chicago, we have now had about just under 300 Chicagoans who have been diagnosed with MPV. What our data is showing us is that most, although not all, of those Chicagoans have been gay, bisexual, or other men who have sex with men, which we sometimes abbreviate as MSM. And just to give you a sense of kind of who some of these Chicagoans are, we're seeing that the median or kind of middle age for most of the cases is 35 years, and there's a range from 22 to 66 years. So predominantly people who are young or middle-aged adults. And MPV is not something that only affects the MSM community. It can affect anyone. You know, viruses know no bounds. But what we are seeing is that spread occurs through tight-knit social networks. And so in this case, what we've predominantly seen is that it is spreading through the MSM network. But that all being said, kind of overall for Chicagoans in general, the risk of MPV does remain low. For those who are concerned about it or might have a new or unexplained rash, we do want people to talk to their healthcare provider. And if they don't have a healthcare provider, then there's several resources available to get people connected to care, whether that's calling our call center at the number on the screen, 312-746-4835, or contacting the HIV Resource Hub, which we also have information on too. And then making sure that people are actually advocating for themselves. So reminding their provider that MPV is in the community, and having a conversation about whether it's worth testing. And then if somebody is actually sick, making sure that they're staying home and avoiding sex or being intimate with anyone until they have themselves checked out. Next slide, please. So in terms of kind of what we're actually doing with MPV, I want to just make the point that there's both tests that are available and then treatment that is available too. So testing capacity has really ramped up and now should be available in many different locations. We have the ability kind of on a national scale to do 70 to 80,000 tests per week. And the testing has expanded from originally testing occurring primarily in public health laboratories to now it's also occurring in commercial laboratories that are commonly used by many healthcare providers. Testing itself typically consists of a swab of a lesion or a rash or a sore that can be collected by any medical provider. And we do recommend that if you do have symptoms that you should get tested, especially if your provider is concerned about MPV. And then treatment is also available. Treatment can be typically supportive. So most people who get MPV get better on their own without treatment or with just what we call supportive care. So that's managing things like pain or symptoms, whether it be with something like Tylenol or baths to reduce inflammation. But there is also an FDA approved antiviral medication called tecovirimat or TPOXX, which can be used to treat higher risk patients and is prescribed through healthcare providers. It's unfortunately only available through what's called an investigational new drug or IND protocol. So there is a significant amount of paperwork that needs to occur, but that can be talked over with healthcare providers and the health department can assist with that as well. Next slide, please. And then I think I'll turn it over to Massimo to go into vaccine in a little more detail.
Thank you, Dr. Cairns. Yeah, so like Dr. Cairns was highlighting, MPV is a virus that we have known about for a long time. However, we're in this moment where it's generating this outbreak with sustained chains of transmission in a way that we have not seen in past. And so while in the past, there are some areas of Central Africa where the disease is endemic, meaning that it may circulate at low levels in that population. We have never seen in advance of 2022 this amount of sustained human-to-human transmission. And so to give you a sense, if in past we would get every year 0 to 1 or 2 cases in the US as the result of some travel, so importation from those areas, we're now obviously seeing, like Dr. Cairns gave us a tour of, sustained spread in many areas of the country. And so in that context, I wanted to sort of, so while we know a fair amount about the virus, thankfully, we have good diagnostic capacity to identify the virus. We have treatment for those for whom it is indicated. And then I wanted to lift up this, the opportunity for vaccination. So thankfully, a vaccine is already available, developed, available, and deployable to communities that are experiencing spread of MPV. And so it is already FDA approved and effective. This vaccine that is primarily used in the context of this outbreak is called Genius. It's the same vaccine that's deployed sort of in many countries around the world at this point in response of the outbreaks. And it has a very good safety profiles and can really be deployed in all individuals who are eligible unless they have a direct sort of allergy to some of the components. However, because the disease has not been previously circulating in our communities, the amount of vaccine that's available nationally is really, initially at least, quite low. And so it is solely resides in the strategic national stockpile. So it is centralized as a asset that the federal government has stocked in a certain quantity. It is not the type of vaccine yet that it's available at your sort of corner provider at the pharmacy. It is really stocked centrally from the federal government and then deployed to public health departments who are responding to the outbreak. And so in that context, in Chicago, we already have received and distributed about 5,000 doses of vaccine. And additionally, we just received this new allotment of vaccine of just over 15,000 doses. We received those over the weekend and we're deploying them fast this week. So in the context of limited amount of vaccine, it really becomes paramount that we administer that vaccine where it can do the most good. So let me tell you a little bit about that. So this vaccine is available and deployed traditionally with the intent of interrupting chains of transmission. And we do this in what is called sort of a ring strategy. So here on the figure, you have the infected case, the round dot, and around it, those who have been in close, intimate contacts with that identified case. And really, of those identified contacts, we can deploy the vaccine in advance of them developing the infection. So that's what's called post-exposure prophylaxis. That's really an indication for whom any identified contacts may and should receive vaccine. And we have coordinated with many providers with the ability to support their patients and the contacts to deploy the vaccine for this context. Additionally, particularly given how the vaccine, the MPV is spreading in our communities, there are many instances because of the close, intimate sexual contact, sort of may or may not identify all contacts. The contacts may themselves be anonymous, so there may be a fair amount of discomfort around sharing the full list. And so you have here on the right, these sort of figures in pink that represents those who may have had exposure and yet haven't been formally identified. And so we are also aiming to deploy vaccine to those who are sort of the next ring out from the identified case. So what does that mean in the context of what we are observing in terms of spread in our community? So as I said, certainly all those who have documented physical contact with somebody or have an intimate partner who was diagnosed with MPV, they should get the vaccine. There are no additional considerations to sort of qualify that eligibility. Additionally, because this is where we're seeing spread, for gay, bisexual, or other cis and trans men who have sex with men, who also either have intimate sexual contacts with other men in a social or sexual venue, or give or receive money or goods for services in exchange of sex, or have had intimate sexual partners with multiple or anonymous partners. So again, to reiterate that we, at present, with limited availability of vaccine, it is really for the second tier, it is MSM with these additional risk factors. At this point, MPV vaccine is not recommended for the general population, and again, also including the same gender-loving men without those additional risk factors. Again, as vaccine supply increases, the guidance may evolve and may include additional individuals who might be eligible. Now, because at present, even with those 15,000 additional doses, it certainly doesn't meet the demand of all the population in Chicago that may be eligible, all those who are at risk of exposure. We're aiming to do the best that these 15,000 doses can do. And that means to deploy them as first doses so that we can reach as many individuals who can benefit from the disease, from the vaccine as possible. Traditionally, the label on this vaccine is indicated as a 2-dose vaccine, at least 20 days 20 days apart. But we're again leveraging the doses we have to focus on delivering first doses. That means that for some individuals, there may be a longer period of time between the first and second doses and second dose while we wait for additional supply to reach Chicago. But certainly there'll be opportunities to receive that second dose once the supply increases. And that is true for most who are at risk. However, we still want to prioritize delivering the full sort of the first and second dose for those who are identified contacts, so confirmed contacts of the case, and or those who are immunocompromised. So to summarize sort of what the activities of response look like from certainly the Chicago Department of Public Health, but also our partners. So we're continuously supporting our clinical providers with the information to appropriately evaluate and test or identify those with MPV and provide treatment when needed. We additionally engage identified cases to identify close or intimate contacts, and we do monitor for 21 days after the last exposure. And then, of course, kind of offer the vaccination opportunity if indicated. To do all this work and to deliver education and prevention messaging, we have engaged a really diverse group of community-based organization, community partners, as well as event organizers to both share information and to partner in sort of reaching those we aim to reach with information and intervention opportunities. And then again, just to summarize, that we deliver vaccine directly to high-risk communities. And as a reminder, it's not at present recommended for the general public. On the right-hand side, you see an example of there's some collateral and media downloads that can be available for many of you on the call to leverage in your settings to communicate information. Here is an example of one, but perhaps we'll follow this with sort of full complement of what is available. Here are additionally examples that include both the palm card as well as some posters that are certainly suited to go up in many settings to inform patrons. And then here I wanted to reflect sort of the best resource for information locally. On the left-hand side is the information for the public, get the facts monkeypox at chi.gov/monkeypox. And on the right-hand side is the provider equivalent of that information. So it's a little bit more targeted to providers, but again, the two link to each other and aim to support our community here in Chicago. Okay, so we'll transition from this summary to question and answers. These are questions that we have received from many, and perhaps some of you on the webinar as well. And we'll aim to go through these and provide some answers, as well as then some opportunity for additional question and answer at the end. So this first one, perhaps for Dr. Karens, what are some ways you can prevent monkeypox?
Sure, thanks. So I think honestly, one of the main ways is to actually have open communication with any potential partners about how they're feeling about recent illnesses, to be aware of new or unexplained rashes or sores. And I think we're aware that this is not always easy, but to try and have that kind of open conversation and thinking about whether you've been sick, they've been sick. And if so, to make sure that somebody, especially if there is a rash or sores, that they see their healthcare provider, that you're not having intimate contact. And then if a partner has a rash or has known MPV, then the best way to protect yourself is to not have sex or intimate contact, to not have any contact with the sores themselves, and to not do things like share food or drink. We even don't want you to do things like kiss or kind of cuddle closely with a partner that may be sick and has MPV, because the rash and the sores themselves are the primary way that it gets spread from one person to another. And then we also recommend not sharing things like towels, bedding, linens, and other things like fetish gear, sex toys, toothbrushes, because that is another potential way for spread to happen. And I think kind of main take homes here is that spread happens primarily for MPV in a way that's different than, say, COVID-19. Spread here primarily happens with direct contact with a sore or rash itself. And it can also spread kind of in a few other ways. So in prolonged kind of face-to-face contact, which is unlike COVID-19, where you think of being within 6 feet of someone for 15 minutes, prolonged face-to-face contact is really kind of more like 3 hours, or through what we call fomites, which are those things like beddings and linens, where they have touched a sore or the kind of body fluid associated with a sore, and then could potentially touch you. Or through things like kissing, cuddling, sharing body fluids.
Thank you. Perhaps one more for you. What should we do if you feel sick or you have new or unexplained rash or sores?
Yeah, and I think this really kind of dovetails with the previous question, but really, if you feel sick, stay home. I mean, I think that messaging is unfortunately very familiar because of COVID-19, but specifically with MPV, if you feel sick or if you have a new or unexplained rash or sore, then you should stay home until you can get it checked out by a healthcare provider. And I mentioned this before, but there are ways if someone doesn't have a healthcare provider that they can get connected to care, and some of those are listed here. And kind of along with staying home while you're sick, it's really kind of avoiding gatherings. And for gatherings, the more that they involve kind of close skin to skin contact, where you could come out in contact, or where someone could come into contact with a sore that you might have, the more that you want to avoid it. And then also, if you think that you potentially could have MPV, then you really want to also think about who you may have had close contact, intimate or sexual contact with over the past few weeks, because that is the time that it can take between when you were exposed and when you actually can develop disease. That's called the incubation period. And that typically is 1 to 2 weeks, but can be as long as 3 weeks or 21 days. And we want you to kind of know that information, because that's something, or if you are diagnosed with MPV, then we want to potentially reach out to those individuals and make sure that they're healthy themselves as well, and potentially seek care if they might have symptoms.
I think we have one more for you.
Oh yeah, so can monkeypox or MPV be spread before symptoms appear? So we just talked a little bit about how it's primarily spread. And so at this point, we don't think that it can be spread before symptoms occur. This is something we're like really looking at closely. But based on all the information that we have right now, because MPV is not a new disease, it can only be spread kind of once you develop symptoms. In terms of symptoms, I think we may get to this, but in terms of symptoms, what we've been seeing is that the vast majority of people have a rash or sores. Sometimes they might not term it that, because it might be, the sores might be like in the mouth, for example, rather than kind of on more traditional skin. But the vast majority of people have that. But then some people, either at the same time that they get the rash or sores, or potentially a few days before, also can develop flu-like symptoms. And that can include anything from a fever, fatigue, headache, those sorts of things. And one of the issues there is that you can potentially be infectious or contagious to others, even when you have those flu-like symptoms as well. So you might not necessarily realize that you could have MPV.
Yeah, thank you. Yeah, I'll take this one. Can I get tested even if I don't have any symptoms? And so there is no screening test at present. So there isn't a test that can be administered in advance of presenting with symptoms. The current testing really is a swab of those lesions or rashes. And so that means that when you develop a rash, that you're worried, the importance of sort of connecting with the healthcare providers, and they'll take that swab, they'll collect that specimen, and they can send it to the lab. Now, thankfully, in the very early phases, this testing was only available in public health laboratories, but thankfully now that test is widely available in commercial, like the large commercial reference laboratories, which means that even settings that have been evaluating individuals for this disease, like outpatient settings, like sexual health clinics, are well positioned to collect that swab and send it to the routine reference laboratories they send other specimens for other diseases to. But again, at present, no screening test in advance of symptoms. So this is a question sort of we get a lot, and I actually saw being posed in the thread as well. Sort of why are gay and bi, cis, and trans people more likely? So the question is if gay or bi, cis, and trans people are more likely to get monkeypox. And here we really want to highlight that there is nothing inherent in the biology of the virus that would select a group of people over another. And so really monkeypox is not limited to people who are sexually active or gay, bisexual, or other men who have sex with men. Anyone who has close physical contact with somebody who is infectious is a risk. The reason why we're seeing at present this spread primarily among MSM is probably the result of the introduction in the virus in a population and then the person-to-person transmission within that network. But we know, sort of experience from other diseases, that it certainly may not stay in that population only. And certainly we have observed, while the vast majority, more than 90% of cases are still within this network. We certainly have seen a few cases outside of this, including a couple of children who had this as a result of somebody in their family infected. So again, a reminder that the virus doesn't discriminate, but the opportunity right now, given that is primarily spreading within this population, to support this population with education, prevention messaging, and vaccination to interrupt the spread as we are currently observing. What is the risk of being exposed at a grocery store, busy coffee shop, CTA, train, or bus? Dr. Karen, do you want to take this one?
Sure, I can start with this. So we talked a little bit before about kind of the ways that MPV can be spread, and I think helpful to also have it written here, but just going over those quickly again. The main source of spread is that direct skin-to-skin contact with rash or sores, and that can and has kind of very frequently among our cases included sexual or intimate contact, and can include kissing. It also does include sharing a house or a bed with someone, potentially sharing towels or unwashed clothing, and then the prolonged face-to-face contact that I had mentioned before as well. That all being said, MPV overall is not very easily spread, especially when you compare to something like COVID-19, which has been, obviously dominating conversations about infectious diseases over the past couple of years. And so MPV is not typically spread through just a casual conversation with someone, walking by someone. It's not even as contagious as flu. And so it's really kind of that prolonged close contact, sharing bedding or clothing, or direct skin-to-skin contact that results in spread. So overall, the grocery store, coffee shop, even public transit are not ways that we've seen this be spread.
Thank you. And maybe this next question is quite aligned. Can I get monkeypox if I use gym equipment or a public restroom after someone with monkeypox has used it? I think this is very aligned with what Dr. Cairns was highlighting. This is very unlikely. Like, again, we're seeing this spread primarily through that intimate, close contact with somebody who's infected. We really have no documented transmission using gym equipment or a public restroom. But of course, certainly sort of for, it applies to this and any other sort of disease spreading in a community, wiping the equipment before and after use, washing hands frequently, certainly after using restroom, it's certainly appropriate. Is there a risk of exposure in a swimming pool or hot tub? Again, highlighting the same main points, right? You've heard now in several different ways how the MPV is transmitted. It isn't waterborne, meaning that differently than other diseases that may spread through water, it does not. And so really the risk, and additionally, the risk of contracting any other disease in a properly maintained pool is quite low. That's why sort of those chemicals are doing their job to prevent transmission in that setting. But of course, that which happens around the pool, so the importance of not sharing drinks, towels, or clothing poolsides certainly fits in that framework of where, aligned with the modes we have described, MPV does transmit. Is there a risk of exposure working closely with coworkers who may be exposed? I think that's the question. Dr. Cairns, you want to take that one?
Sure. So I think this goes back to kind of the other questions that we have just talked about. So again, like risk of spread to coworkers is low, unless you're having kind of one of the above, one of the like other types of transmission. So sexual or intimate contact, direct skin to skin contact, that you're like living with a coworker, things along those lines. What I can say too is in Chicago, we have not seen any spread between coworkers. And what the health department does is we talk to individuals who've been diagnosed with MPV, and we ask them about close contacts, and then we evaluate their risk levels too. And coworkers, we have not even seen be high risk or really even needing kind of the vaccine because they've been exposed. So really risk of spread to coworkers is quite low.
Thank you. And this is a question that we get a lot. Do I qualify for, and where can I get the vaccine? So again, as a reminder, we've sort of highlighted that the vaccine is indicated for somebody who has had physical contact with somebody who was diagnosed for MPV, and that is sort of priority one. And we connect providers, we connect individuals to that opportunity to get vaccine. And also those gay, bisexual, and other cis and trans men who have sex with men with those additional risk factors. Now, it is fair to recognize that while we want to deploy the vaccine we have among those who are eligible, it's certainly at present, there isn't a supply sufficient enough of vaccine to meet the needs of all who may be in that lane too, of those who are eligible by the likelihood of risk. So to ensure that the vaccine goes equitably across those who can benefit most, we have done a few things. First and foremost, engaged with a cohort of diverse partners across the city. Here is a table that you'll soon see on our website, and it represents a complement of partners that, along with the Chicago Department of Public Health, are deploying vaccine to these eligible individuals. So we have partners at Howard Brown across the city, a few other sort of clinical settings, as well as partners in FQHC, Federal Qualified Health Centers, like Esperanza. And then we also have Rush University and UIC represent partners that are able to provide their clinical capacity, so administering vaccine, in settings, so either community-based organization that host vaccination events or venues, so private spaces, that based on the population they cater to may, they're sort of well positioned to engage the right population to get the vaccine. So this isn't a complete list, and the list will grow, and it'll continue to grow both by number of partners of vaccination opportunities across the city and by volume, so amount of vaccine to sustain current efforts and expand as we go. So I'll just introduce this briefly. It's sort of, front of mind, given where we're seeing the disease spread, thinking about events and opportunities that bring our community together. And we certainly have market days coming soon, front and center. And so I'll give sort of some high level updates there. There've been a sort of multiple partners and engagement opportunity here. But I'd say that first and foremost, awareness and education. So regardless of vaccination opportunity, the importance to do all that each of us can to protect the community affected, to protect ourselves from exposure. And again, we'll disseminate sort of the many products that can be leveraged by many of you to disseminate this message. And then I'll let, maybe I'll talk briefly about additional vaccination events. Again, these will be in settings sort of away from where the public space for most of the festivities will be, but will provide some opportunities to vaccinate during that time in sort of clinical spaces or venues adjacent to the festivities. And then I'll let Patrick to tell us a bit about other outreach efforts and engagement in the space.
Sure. So specifically, we're reaching out to a bunch of different partners, including the individuals who've been mobilized to perform a COVID response. So the COVID Community Response Corps, which has been involved in doing event-based activities around COVID. And they, in fact, doing like Pride Fest last year. So we're working on finding the individuals who are best equipped to provide this work at market days, come and be present at both entrances so that they can answer questions, have conversations with folks, gather feedback and questions from folks, direct people to resources that are available at market days, as well as probably just like handing out water. Because in addition to making sure that individuals are aware of what's going on with MPV, we want folks to be otherwise healthy as well. And that means being hydrated. It's a big thing I talk about on a lot of our community partner meetings regarding MPV. And so they'll be at the entrances and exits, passing out information and directing folks with answering questions, but also wandering throughout the event. Just to see what can be seen and have the conversations that folks want to have where they're most comfortable. In addition to them, we also have a number of delegate agencies over in the Syndemic Infectious Diseases Bureau who are regular participants at market days, and so would already be there regardless of what's going on with MPV. And so we're working with them to make sure that they're able to carry the information as well, so that it can be as much a part of the how to have a fun, healthy experience as possible, and not so much the like look out for MPV. It is look out for MPV, but also in the course. So like, we want you to be out in the sunshine and having fun. We just want you to do it in a safe and healthy way.
Okay. Thank you, Patrick.
Yeah.
So we'll keep going on questions. I think we clustered these sort of as they may apply to an event such as market days, but certainly they apply to other settings as well. We've received these questions about, is there a risk of exposure dancing on a crowded dance floor or sharing a drink with others? And maybe I'll attempt here, but others feel free to sort of chime in and enrich as needed. I think broadly, we can think of risk across a continuum. So it really depends, meaning that an event outside, it's certainly less risky than a crowded space indoors because of the opportunity for crowding and that skin to skin. And then I introduced this element of like, it really depends on how much clothing you're wearing. So really, we have a disease where a very readily available intervention is a layer of clothing. And I am aware that not all settings are suited to this, but it's certainly readily available to remove sort of that risk by simply wearing more clothing. And I know it's summer and it's time to have a good time, but here is a readily available intervention. I also say that it's really about opportunities. We have learned this through COVID, right? Putting a mask on, exercising a bit of personal space, certainly the distance, and so avoiding that opportunity for direct contact, as well as the clothing, the barrier that we can provide is sort of the appropriate intervention. And as we think of events, there's certainly the amount of crowding and the amount of personal and, the amount of skin to skin contact that there is sort of then elevates the potential risk among groups where the disease is spreading. And certainly avoiding sharing drinks with others. Sort of that is one of the ways in which the disease may transmit, and sort of that is appropriate to avoid. And then a reminder that sort of the higher likelihood of spreading MPV, and again, this comes out clearly when we identified and investigate individuals who are infected, that really where there are enclosed spaces such as back rooms or sex clubs, or where really the front and center of the activity is the intimate sexual contact, that is where we're seeing spread occur. So I don't know if Jenna, you want to add anything else there?
No, I think that's right, Massimo.
Great.
If I may really quickly, Massimo,
Please.
not just drinks, but like sharing things. Like I'm thinking about like sharing cigarettes or
Oh, awesome.
vape pens or whatever the case may be, right? It's not just there's nothing about a glass specifically that it would be the path of transmission. It's the having something in your mouth and then giving that to someone else. They put that in their mouth and so on and so on and so on, right? So I'm thinking back like during the meningitis outbreak several years ago, there was some social media going around that was just puff puff don't give.
Yeah. Yeah, thank you for that. And again, this kind of being attentive to any rash on ourselves or others. And so, I've been really leaning into this idea that like, if you feel ill or, the intimate partner you're about to engage with feels ill, if you see a rash on yourself or the partner, really that is the time to take a pause, right? To take a step back, to not, certainly if for anyone who's feeling ill, to not participate in an event and really kind of seek care and remove themselves from others. That's first and foremost the way to avoid onward transmission and exposures. And then again, because the two things may not be perfectly in sync in time, any sort of observed new rash or sores being an indication for the same.
Massimo and Jenna, we got a question about risks to delaying the second dose of Jynneos vaccine. Are there risks to delaying the second dose?
Yeah. So again, I'll start. Maybe Jenna, you can enrich. The strategy right now of using all the doses as first doses is also being deployed in other areas here in the US. So New York is doing something very similar. Canada has done the same, as well as the UK. And it is reliant on data that identifies that first and foremost, like with most vaccine, the initial sort of boost in immunity comes after the first dose. So we have some data that compares this vaccine with another vaccine that's been used in the past for this disease. And after 2 weeks, the amount of immunity is really nearly the same. It's sort of really the same. And at that point with the other vaccine, it was, so there's some data that indicates that there is protection. So some confidence that the first dose really does quite a bit of kickstarting of the immune response. And then additionally, the fact that delaying the second dose, so receiving it sometime after those 28 days have elapsed, does not impact the overall additional immune response that's gained after that second dose. So in other words, to delay that second dose, it doesn't diminish the benefit from both. And in some ways, it makes me think how the UK have done this for COVID, for example. If you remember early on, they had done much of the same, sort of delaying that second dose, and actually ended up being sort of more robust in terms of the overall protection over time. Oh, and I also, just since we're in a bucket, I've been trying to keep track of questions in the chat as well. This element of thinking of reinfection, let's address this, because I think these two things may be linked. And this is very different than COVID. So SARS-CoV-2, the virus that causes COVID-19 disease, is an RNA virus, is rapidly evolving. You have probably heard all about the many variants and subvariants thereof. It rapidly mutates. Is RNA simpler genetic material that doesn't check itself as it copies? MPV, monkeypox virus, is actually a double-stranded RNA. And so in the way it duplicates through generations as it transmits, it has some mechanism to kind of error check as it copies. And so as a result, it mutates much less rapidly. And therefore, we expect much less opportunities of reinfection. And in fact, we think sort of that prior infection, like somebody who was infected in the current outbreak, to be quite protected, and in fact not in need of receiving a vaccine as a result of this.
Dr. Cairns, there are some questions about whether or not the virus lives on surfaces like door handles or countertops, and a few questions about clothing in clothing stores. If someone who has monkeypox tries on clothing in a clothing store, leaves, and then someone else tries on that article of clothing, is there potential for transmission? So getting at, I guess, the amount of time exposure needs to happen, and whether and how long the virus can live on specific surfaces.
So the virus can potentially, live in kind of body fluid that then has contact with something else, which is why we say it can potentially spread through things like, wearing someone else's clothes or linens. That all being said, the virus is also easily killed by things like disinfectants, by things like sunlight. I don't know off the top of my head like the exact amount of time that takes, but it is very unlikely that spread would occur, say, through touching a doorknob. And although like kind of theoretically possible that someone who has MPV, who had, a sore, tried on clothing, then took that off, and then another person tried it on, that it could potentially be spread that way. I think also pretty unlikely that will happen. I think someone else, I was also just trying to screen through the questions. Someone else just asked a question, or at some point asked a question about kind of the percent of spread that we've seen through sexual or intimate contact. And I think for our cases, we have to relook at this data, but something we have been looking at, and, it's really kind of 95% of our cases have likely occurred through sex or intimate contact. So just to kind of give a sense that spread is not really occurring kind of through these other mechanisms, it's really kind of that close skin to skin contact that is the primary means of spread.
Thank you. And maybe Dr. Cairns, this is well aligned. Sorry, is monkeypox sexually transmitted? I'll speak to that.
Yeah, sure. I can address that too. So I mean, we don't yet know, although we're looking into it, kind of public health in general, whether a virus can actually be transmitted through vaginal or seminal fluids. But that being said, sex, intimate contact, that is close contact, and that really is how we are seeing spread occur. So it's really like difficult to necessarily differentiate by the technical definition of kind of sexual transmission, where spread is occurring through vaginal or seminal fluids. At this point, we don't know that that's occurring. We don't think so, but having sex with someone is a potential means of spread through that direct close contact.
Thank you. And maybe just briefly, this is all well aligned. There's a question about risk of exposure during hugging, just highlighting again, a casual hug being different than hugging and cuddling during intimate contact, that being the primary mode of transmission. How can you lower your risk during sex? Dr. Cairns, do you want to walk us through this?
Sure, yeah, I can take. Oh, go ahead.
Go ahead. Go ahead, Dr.
Oh, sorry. Yeah, so I mean, there are ways to lower risk during sex. One of those is to not actually have in-person contact. And that can be like having sex virtually, masturbating together at a distance, or without touching each other, or without touching any rash or sores. Avoiding kissing and sharing saliva, making sure to clean hands, bedding, towels, clothing, sex toys, fetish gear before and after sex, and then limiting the number of partners to avoid opportunities for MPV to spread.
Great. And I guess just briefly, relating to this question about wearing a condom being protective for monkeypox. Again, like Dr. Cairns was highlighting, sexual contact is the primary mode of transmission. And even when wearing a condom, the skin-to-skin contact still occurs, right? So again, while it may be very important to wear condoms and reduce the risk of other sexually transmitted diseases, HIV, gonorrhea, chlamydia, and syphilis, it really doesn't eliminate the primary mode of transmission, which is skin to skin. However, sort of beyond the importance of generally leveraging condom use as appropriate, to also highlighting for the protection it may have for those who have been diagnosed with monkeypox to, in an abundance of caution, sort of wear condoms for at least 8 weeks after resolution of symptoms. So after having completely recovered from MPV, to continue condom use consistently until at least 8 weeks after. And maybe this question, in the spirit of time, so to get some of the question from the attendees, this is perhaps aligned with other content that certainly sort of kissing and giving or receiving oral sex all fit within the elements that we're seeing as contributing to spread. So they're definitely areas of concern. And I just wanted to make sure, well, I saw some requests for slide sharing. I think both the full webinar along with the slides can certainly be shared. And then I guess we'll turn it over to navigate a few of the questions as posed.
We do have some questions. We actually have a lot of questions. What makes someone high risk?
Yeah, go ahead.
What makes someone high risk? Can you hear me?
Sorry, Massimo, I'm not sure if you were planning to
Yeah,
address
go
this
for
or
it.
not. Oh, okay. So from what we're seeing in terms of data, this goes, those who are high risk are kind of the same criteria as those who are eligible for the vaccine. So those who've had close contact with someone known to have MPV, gay, bisexual, or cis or trans men who have sex with men, who have multiple or anonymous sex partners, have had sex in a social or sexual venue, or have exchanged goods or money in exchange for sex.
Yeah, and I guess I wonder if I, having a bit more familiarity, if I can go through a rapid round of questions that highlight elements that we may not have covered. Perhaps I'll go through a few of those. One that I'm landing on is, can you get it in your linens in a laundry machine? I presume a shared laundry machine where somebody infected may also use. You want to go ahead, Jen?
Yeah, I can take that one. People who have MPV can do their laundry kind of in a normal shared washing machine. The virus is killed by just normal laundry detergent, kind of washed in a washing machine. So there should not be likelihood of spread in that way.
Great. And does the rash sore occur only in the areas where one has been in contact with somebody who has the virus, or does the rash sore spread throughout the body?
That's a great question. The rash or sores can occur in kind of both locations. So one thing that can happen is you can actually spread the sores kind of even along yourself. So we do see that sores tend to occur where there has been contact. For example, we're seeing a lot of patients who have sores in the genital or anal regions, but the sores can potentially also spread to other locations. So many patients also have sores kind of on the chest, the arms, the hands, feet, face even. Some of that can be that if you are kind of, itching or kind of bothering at a sore, you can potentially spread it to other locations on yourself. But the virus also does get into the bloodstream and can spread to other parts of the body that way as well.
And can you reiterate both the incubation period and how long an individual infected may be infectious?
Sure. So typically, after you're exposed, it takes 1 to 2 weeks before you develop symptoms, but that can range anywhere from about 5 days to about 21 days or 3 weeks. And then, I'm sorry, Massimo, what was the second part of the question?
The infectious period.
Oh, okay. And people are thought to be infectious or contagious to other people, so able to spread MPV. It varies, but typically about 2 to 4 weeks. So really you're thought to be able to spread it to others until the rash or the sores have healed fully and the scabs have fallen off and new skin has grown underneath. And what we typically see is that that can take quite a while, so 2 to 4 weeks.
And then there are a few questions that I think are in the bucket of methods to disinfect hands or laundry, etc. And certainly hand sanitizer along with washing hands with soap and water is appropriate and effective in inactivating the virus, as well as standard cleaning agents for surfaces on laundry as well. And then there's a question about MPV vaccine available for healthcare workers. Maybe I'll start there, but feel free to add, Jenna. Sort of at present, there is no indication for healthcare workers to be vaccinated for MPV. And this is really a reminder of how the virus is spread. It really requires that direct skin contact. And for as long as that interaction is sort of done appropriately with what we call standard precautions that eliminate that opportunity, it doesn't present a direct risk to healthcare workers. We at the health department have monitored hundreds of healthcare workers who have evaluated individuals that turned out to be positive. And this is done sort of uniformly across the country. And I've seen no evidence of transmission to those who care for patients with MPV. Those who have had smallpox vaccine, are they protected against MPV? Jenna, do you want to speak to that?
Sure. We don't know how much protection is still provided by a smallpox vaccine, especially if it was given kind of many years ago. So smallpox vaccine kind of in the US was widely available, I think until maybe the 60s or so. So we do know that the immunity from a smallpox vaccine does wane over time. And so people who may have been vaccinated as you know, a young child or even kind of as a healthcare worker may still be eligible for vaccine if they kind of meet the other categories. I believe it's if it's been kind of more than 2 or 3 years since you were previously vaccinated, then you can be eligible if you meet one of the other criteria to get vaccinated.
Great. And I know we're at time, but recognizing that there are many more questions. So we'll certainly engage in this and provide additional answers there, and we'll post those on our publicly available website. But I'll leave it to others if additional considerations or remarks. Patrick, I see you.
Yeah, thanks, Massimo. Just very quickly wanted to say thank you to everyone who's participated with all of these questions and concerns and ideas and suggestions. This is wonderful. This is exactly why we wanted to have this kind of a conversation. We will be capturing all of the questions in the chat and in the Q&A section and typing up responses and making sure that those get out to everybody. So just from my side, thank you again for what is already a very useful and productive conversation. So thank you.
Thank you to the Department of Public Health for today's presentation. I believe it was very informative. We had over 200 people log in today to get all of this information. If you are a part of the BACP Entrepreneur Certificate Program and would like to receive credit for today's webinar, please send us an email to bacpoutreach@cityofchicago.org. Your questions, again, will be copied and sent over to the Department of Public Health for them to answer your questions. So please continue to check their website for updates on monkeypox. And thank you again to the health department. Thank you.
Thank you, everyone.